Hello and welcome to EMS Research with Professor Bram, where we talk about the research-related issues to those who work in emergency medical services. Today we'll be talking about the use of ultrasound in the field by EMS. Welcome to the EMS Research Vlog and Podcast from the studio here in Houston, Texas. I'm your host, Bram Duffy. I'm a full-time paramedic on the street like many of you. I also have an appointment as a research fellow with the Institute for Social Innovation at Fielding Graduate University, and I'm an assistant professor of communication at Kennesaw State University. I actually have a research study open now for first responders, so if you don't mind being interviewed by me, then go to my website and check it out, www.professorbram.com. It's professorbram.com. You just click on the current research tab to apply. The other thing to share before we get started, I have written 2 different books on communication. And the most recent book was just released called Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. You can find a link to the book below. Also, for sure, hang out to the end and I'll tell you more about it. So for today's show, I would like to introduce Dr. Gordon Johnson. Dr. Johnson is a hospitalist at the Legacy Emmanuel Medical Center in Portland, Oregon. He's also a co-author of a research study that was published in the POCUS Journal called Demonstration of a Longitudinal Medical Education Model to Teach Point-of-Care Ultrasound in Research-Limited Settings. This research article is about a study done to see if long-term teaching program could help doctors in places that don't have a lot of resources. So like in rural Haiti, they were able to use the special tool called this point-of-care ultrasound. And so that's ultrasound at the site and not read later. This tool can be, if it could be used right at the patient's bedside, then we're able to help out with diagnosis significantly. So the researchers trained the doctors by having volunteers from the US and Europe teach them on one-on-one over 4 months, and then they tested the doctor's skills before and after the program to see if they improved. The results were really, really good. They got better in almost all the important areas that they were tested in. And so this study that Dr. Johnson put out there really shows that this kind of long-term teaching program works well in places that don't have a lot of resources. And it can help people when we're trying to figure out things about serious diseases or death that can result without figuring out what's wrong with these folks. And so it also just doesn't cost the patient anything extra or put them at any more risk. And so this was really awesome to be able to check out about this from Dr. Johnson, and he's on the show with us today. Dr. Johnson, welcome to the show. I know you have a lot more to share. Can you start out, just tell us about yourself and maybe add to this research article?
Sure. Just briefly, so I'm an internist, but work mainly as a hospitalist now, but I've done a lot of work. My passion is really global health, and I went through a fellowship in point-of-care ultrasound back in 2015-16 to really formalize my skills to do this, and have had wonderful opportunities, including working with these 2 wonderful professors we'll talk to a little bit later from Norway. But around this study, and we'll talk a lot how this would pertain to EMTs, of course, but we'll start out with the study. So what we were trying to show was the benefit of a long-term teaching program in an area, because typically, I think in the past, what we would do, a group of us maybe would fly into Houston, Texas, and teach some of your EMTs over a week and then fly out. And what we found was people would really get some great skills to do point-of-care ultrasound, but then they would kind of degrade over time. So the idea here was for a couple of us to fly in at a time, do some teaching, come out, have another group come in a couple weeks later, and then over 4 months have this sustained program, and hoping that there's better education and skill over that time in a resource limited setting like Haiti. But I always remind people we have many resource limited settings throughout the world, rural areas, even places on the weekend where you may not have people skilled like Victoria here, who's a ultrasonographer, and it's up to maybe an EMT or an internist like myself to do an initial scan of point of care to come to the diagnosis.
So could I just ask you, why is it so difficult? I know there are lots of skills out there, like, if you don't practice IVs enough, you're not going to be great at sticking. But why do you think this is a skill that requires multiple learning interventions to make sure?
Yeah, that's a good question. But I mean, if you look at, and we are not ultrasonographers, cardiologists, echo techs, but those skills are at least 2-year degrees to get the skill to be able to obtain these images. And then we have to obtain images and interpret them. But I do look at it differently, Bram. Like, you just put up IVs. I mean, we can teach a nurse in, I don't know, half an hour to help use an ultrasound and get them started, aiding them doing difficult IVs. So I'm thinking point-of-care ultrasound and more of a step-line approach. And then, the point where I can do a cardiac echo and interpret it in a basic sense. Again, we're not cardiologists, and I want to be clear about that. That might take me going to a 2 or 3 day course, even just to get the basics. So there's really, like a lot of things, a wide variety of the skills. And I guess the best one to start out with would be bladder rather than putting an IV, because that's a little trickier with an ultrasound. But, you're an EMT, you go out to a home, somebody can't urinate, teach you to look at the bladder, see if it's 1,000 milliliters or 10, that we can do in a half an hour. So it's really variable what you're trying to do and what you're trying to look at.
That's pretty awesome. I didn't, I was thinking about other uses. I didn't think about it being a bladder scanner also. That's pretty awesome.
Yeah,
you also invited two other guests today to talk about the application of ultrasound. Do you want to go ahead and help us introduce them to our audience?
Yeah, just briefly, I want to just be clear that point-of-care ultrasound, the thing that's unique about it is ultrasound at the bedside or in the field. And how are we different from an echo or an ultrasound that's done in a formal setting in a radiologic center? We usually have a binary question. Like I said, is this bladder retaining a bunch of urine or is it not? We're not looking at the bladder looking for tumors when we're out in the field. And that's how we're really different. And then the difference also is the person that's doing the scan is also interpreting it. I'm not sending it to a radiologist or a cardiologist to interpret. So that's what I want your audience just to be clear about, the difference here. To start, Victoria Vatsvåg, she is an ultrasonographer from Norway, Stavanger, Norway, trained in the UK, in Ireland, I believe, and very active with ultrasound education with all of us, and then also getting her PhD now from the University of Stavanger. And then her associate, Dr. Nils Peter Overland, he is an MD PhD. He's an anesthesiologist, spends a lot of time in the Air Ambulance there. So I think he'll have a lot of good information for your audience here, and very active in research as well in Stavanger. So go ahead, Victoria. Why don't you tell us a little more about yourself there?
Hi, how are you? Good to see you. Thanks for the introduction there, Gordy. My name is Victoria. I work here in Stavanger on the southwest coast of Norway. So I have a background as a radiographer, and then did my master's in ultrasound. So I've been working as a sonographer for many, many years. And like Gordon here said, I am also involved in a lot of teaching, both here at the University of Stavanger, but also other universities around Norway, and courses and conferences around Norway and in Europe as well. I'm also a PhD student here at the University of Stavanger, where I focus on teleguided ultrasound, so remote ultrasound. Yeah, that was a short intro for me.
Awesome, welcome.
I think in particular, I know you do some teaching out on the oil platforms where there can be pretty bad accidents that need attention very quickly. Can you tell us about your research out there? I think that's very interesting to start.
Yeah, absolutely. So one of my projects involves specialist nurses who work offshore. So off the coast here of Norway, we have a lot of oil rigs. They don't have any doctors out there. They have specialist nurses who work at the offshore health clinics. And up until now, they haven't had any access to medical imaging out there. It'd be a bit difficult to fly out a CT machine or an X-ray machine. So we're trying to introduce ultrasound as a standard test that they can do out there. And like Gordon said in his introduction, it takes a lot of time and a lot of practice to obtain the skills where you can scan, but you can also interpret what you see on the ultrasound scan. So in my project, I act as a remote specialist. So the nurses are trained to do the scan, but I am the one actually observing the scan in real time while they're doing the scan and interpreting what they see. And like you said, it is not often that quick to get a patient from an offshore oil rig onshore. It can take a few hours, and sometimes if the weather is really bad, you can't really fly at all. So it's a great help and a great assurance for the patients out there.
Over to me. Thanks, Bram, for having me on the show. I just realized that Houston, Texas is a friendship city to Stavanger, actually. It's one of our American friendship cities. So that makes a lot of sense. We are oil and gas production in Norway, and we also do a lot of medical things here.
For sure.
So thank you for that, and thank you for the introduction, Gordy. So I work in the Air Ambulance service in Norway. It's a bit different organized than in US. We have a lot of doctors and primarily anesthesiologists that will go out with a helicopter together with paramedics to treat patients. And from 2015, we started implementing point-of-care ultrasound into this service. So because of the machines is getting smaller and smaller, it's portable, we found out, okay, if we could get skilled with this, we could bring it to the scene of the accident and actually utilize it to diagnose and to quicker and better treat our patients. So I've gained a lot of experience in this field. My PhD is in lung ultrasound, so I'm especially interested in how we can diagnose a pneumothorax, for example, or a hemothorax, which is really useful if we can kind of hit the diagnosis directly and start treatment at the bedside. So I think that's the core of what this tool can help us with. And I've been teaching alongside Gordy and Victoria for years now. And as you can hear, we are quite passionate about this, and we're looking forward to some fruitful discussions on the show. Thank you.
So when we talk today, let's just assume that no one knows anything so that myself and my guests can catch up. And to start that out, would someone like to kind of explain the point-of-care ultrasound and how it works in sort of simple terms?
Yeah, I can jump in here. So to make it very simply, it's an ultrasound that basically plugs into your cell phone. You know, it's very portable. I mean, it doesn't have to be. There's also cart-based devices, which would be explained like an ultrasound that's like a laptop, I guess, is usually what you think. It's generally portable. Again, that's what makes it different. And then the real difference for me is this binary question, a targeted question you're trying to answer in the field. And I am the scanner as well as interpreting it. That's the big difference, I think. Do you guys have anything more to clarify about that?
I think you're right, Gordy. So if you compare it to what happens in a hospital, the doctor might order an X-ray. It can take 30 minutes, 60 minutes to take the picture. Then you get an answer back. That's not point of care. So I think the crucial thing is that it's the clinician, him or herself, that is doing the diagnostics using this portable tool. That makes it powerful because it can guide the treatment there and then.
I think I can just add, I think, Bram, what you might be referring to when you said explain things in simple terms. So if people don't know what Nils Peter said, what a pneumothorax is, it is a punctured lung, basically. And you can't say for sure if the lung is punctured just by looking at the patient and touching them and listening to their chest. So with ultrasound, you can see straight away if the lung is punctured or not. So that is a binary question. Is there a sign of a punctured lung, yes or no? And then you can use your ultrasound. It takes a few seconds and you can answer the question rather than having to wait until you've transferred the patient to a hospital, bring the patient over to a CT bed or into the X-ray room, do the X-ray, wait for the reports, and then being able to answer the question. So it makes a huge difference to the time spent to diagnosis.
So let's assume everyone's at least paramedic level, because I think that our audience is mostly paramedics, nurse and physician level. And it's just that it's not a technology that we get to use in the field. And so help me out with this little quiz. Like, can we all list together some of the things that can be diagnosed just right away? We talked about the lung trauma stuff, but what about like if we're going to be looking at the heart, can we check for fluid there, or is there? Tell me more. But can we help me just list some stuff, because this is exciting.
Yeah. Can I jump in really quick? Because that's what I was thinking with your EMT. So cardiac, again, we are not cardiologists, but you have a PEA arrest. You're going to put the probe below the heart in what we call the subcostal area. Someone's doing CPR on the chest. You switch providers. You have about 3-second window to look at the heart. And with PEA, the differential cardiac tamponade, I can see a bunch of fluid around the heart.
Yeah.
Hypovolemia, I see a hyperdynamic heart. A huge PE, I see the right heart is really enlarged, okay? And then often an agonal rhythm for an electrolyte disturbance, or when people, frankly, are dying, and I see this heart barely moving. It really narrows down that differential quickly and changes what you would do in the field. If someone has cardiac tamponade and they're really checking out, you're probably going to put a catheter in there and try to drain that.
Right.
So, you can see the advantage there, where otherwise you're giving fluids and epinephrine and transferring to the hospital. That's one example, I would say, of looking at the heart, and particularly pertaining to EMTs. There's many more that we do. Can you guys, Victoria, can you jump in with another example?
Like you say, we're not looking at any fine details. We're not doing any fancy measurements or anything when we do point-of-care ultrasound. We're looking for growth and pathology. So like Gordon said here, if you're looking at the heart, it's not any measurements or anything. You're just looking for, is there fluid, yes or no? Is the heart pumping, yes or no? And you said, Bram, what can we look at? We can look at pretty much everything from head to toe. In trauma, in addition to looking at the heart and the lungs, obviously you can look for bleeding or for free fluid in the abdomen. You can even look for fractures with ultrasound. Even if you kind of look through bone, you can look at the surface of bone and identify any fractures. So there is a very long list over things you can examine without doing anything fancy.
Well, when you mentioned the ability that you have to look at the heart with something like this, I just am thinking about how through my years as a paramedic, both in the ER and in the field, I've been in hundreds of CPR situations, and the number of times when I've seen ultrasound pulled out during that cardiac event is almost zero. It's not zero, because I know some trauma cases that I remember, but like that is, just to share with you all, that is surprising to me from my perspective, because I don't see that being used. What I do see is I see a lot of assumptions made, like, oh, we're in PEA, that must mean this. And so I'm kind of in shock, because I'm realizing here that Dr. Johnson's saying, hey, we can confirm some of this stuff. We can. And so I actually want to say that I don't know that it's used as often as it could, even when you have it available in the ER.
It's interesting, Bram, when you talk about PEA, because ultrasound is actually kind of introduced another concept that we call pseudo PEA. So when you use ultrasound during cardiac arrest, we differentiate between a real standstilling heart, where you still have electric activity, which we call a real PEA. But with ultrasound, you would sometimes see that the heart muscle is moving, and we will call that pseudo PEA. And actually, studies show that those patients has a higher chance of survival, because the muscle is really trying to survive, and we can actually see that. But we can't feel the pulse, but we can actually with ultrasound see that the heart is beating. So there are new information that we can get by introducing this.
So in that case, we would think, okay, now my patient has a heartbeat, but they just don't have a blood pressure. Is that kind of the idea that would give me? I would say, okay, it's not just the electricity, the mechanical parts there. It's just not the perfusion isn't strong enough to feel blood pressure. Isn't that what that would tell me? Or
yeah, it's you will actually see the heart is beating, but it doesn't generate a pressure, as you said. You can't feel the pulse, but the heart is still kind of active. There is some movement in the muscle. They will have a higher chance to get a return of pulse compared to like a real standstilling heart. You might sometimes see that there is coagulated blood inside the heart, which is kind of signs that the patient might have been there for a long time without cardiac activity, and there is no use continuing. So it will be a helpful tool in those situations for sure.
The other thing I think of in these arrest situations is pulse checks and how insensitive they are, really. But you can put an ultrasound on the neck and look at the carotid, and we have something called Doppler color flow we can look at, and we can see if there is actually a pulse in the vessels much more accurately than trying to feel with your fingers in the crash situation, and especially if the patient is obese. We know how poor that study is. So again, these simple binary questions, and we could train somebody, maybe not to do cardiac, but be able to identify a pulse or not.
So I agree with that. And again, just to answer the previous questions, what can we use this for? I like to view it as a visual stethoscope, because instead of listening, you're actually looking. And we talked about punctured lung and pneumothorax. It's a great tool for that. Also to look for fluid, either around the lung, around the heart, or free fluid in the abdomen. I would also like to add looking at the aorta. So be able to see if the aorta is dilated and those kind of conditions. And I was never able to diagnose before I got this tool. So just all these kind of things where your eyes is better than your ears would be helpful.
This is what we're always trying to do. We're always trying to diagnose our patients, but it makes me wonder, is the diagnosis always going to be worth it? Because, when we're in EMS, there are different situations where you might be in a city where the hospital is 15 minutes away. So do we want to, go through that? But at the same time, we might be taking the patient to a hospital that we know is so busy, they're not going to see a doctor for the first hour, right? So I think this is sort of situational. So it makes me think, first, is it worth it from the perspective of, yeah, now I know what's going on with my patient for sure, but how much is that going to change the treatment? And so far in our conversation, I got that, well, I'm going to have a good idea if the cardiac arrest is viable or not, right? So I can know if we should continue or not. But how about as far as actual treatments that might be done to see if it's worth it, right? To see if this is going to be an intervention that we make in the field.
When Nils Peter to jump in here quickly, but I would also say it helps triage. So he was mentioning the FAST exam. You might have heard of a focal sonography in trauma. And if the abdomen is full of fluid, you're worried about hemorrhage. So that's going to triage that person into that ER. Hopefully won't have that hour wait with a positive FAST exam. But the other thing I want to mention is in Norway, if I'm translating correctly, they call it clinical ultrasound. So if I'm a 50-year-old cirrhotic, I may have fluid in my abdomen all the time. If I'm a 30-year-old female that's pregnant, I've got acute onset abdominal pain, that might be an ectopic pregnancy. And if I've got a little bit of fluid on my abdomen, that's an emergency. So you have to also put it into the clinical context when you're doing ultrasound. But can you two give us more examples of how it helps you triage patients?
Yeah, I would use the phrase 4 T's. So I would use ultrasound to try to alter treatment. That's the first T. Obviously, you want to do treatment A or treatment B. So that's where we could use it. Number 2 is you mentioned triage. I think that's an interesting concept. Normally, I would only have one patient. But if we go back to Italy in 2020, the pandemic, they would use ultrasound in the ER to triage whose patient is admitted to the hospital and who's not. So there is all these kind of things you could use to kind of prioritize between your patients if there is a lot of patients at the same time. The third T is transport. So in Norway, we are a long country. There is not the best roads and so on. So we would either go for car ambulance, we could go for helicopter transport. We can even go for fixed wing or flight transport. So we could kind of use the ultrasound tool to help us with, decide which kind of treatment transport is best. And the last T would be team preparations. And that's important to me because my philosophy is that the more that I know about my patient as early as possible, I can prepare the team that is going to take over that patient. So that would, in my case, be the team that will take over the patient in the ER. And if I can give them a good, fully qualified report, I can prepare them to get the optimal treatment of the patient and make sure that they don't wait for an hour if there's an emergency, which can be fatal in some cases. So there is these 4 T's that I always bring with me when I use this tool.
Thank you for that. It makes me wonder how the progression of this is going to hit EMS across the world, because we have these technicians that a lot of people see as just that, just technicians, not people that diagnose, not, basically just Band-Aid people to get someone to the doctor. And this really adds an incredible diagnostic tool to this. And so it makes me wonder, how is that going to be received? I remember one time I was transporting a patient that had a AAA to a thoracic surgeon, and the patient was in a very serious spot, because I remember starting out with a blood pressure just around 90, and in about a 30-minute period, I went down to like 60. And so I had an argument with the thoracic surgeon because he wanted to scan her again before surgery. And I told him, like, we just don't have time. And I had a full-on argument with him trying, this was about 20 years ago, but I had a full-on argument with him because I know you don't talk that way to surgeons, but I also knew that this patient wasn't going to survive that, that additional scan. And so the patient did die, and the patient died in the scanner right after we had the big argument. But it's like, it always makes me think about, how much trust do the intervention people have in what information is being told to them. And in this case, we had a scan from the outside hospital plus a falling blood pressure, and it was scary. So, in these cases that need emergency surgical intervention, I wonder about the struggles that paramedics are going to go through to talk surgeons into going ahead with a knife before spending more diagnostics in the hospital when it's needed. What do y'all think about that?
Yeah, that's a good point. And fortunately, a lot of these struggles have been done before us, mainly with ER physicians. But like I said, I keep referring to this with the cardiologist saying, what are you guys doing with these probes? You're dangerous. You don't know what you're looking at. You're not getting good scans. Radiologists worried we're in some kind of turf battle. It clearly is not. So fortunately, those struggles, I think for the most part, are over. I'll tell you, though, one way to really make it hard on yourself is to overinterpret. To get a cardiac scan, you really can't see very well, and you tell the cardiologist, oh, the EF is fine, or it's low, and it's not. Mm-hmm. So I would encourage your audience, don't be afraid to say non-diagnostic scan. I'm bringing a patient in, they've got abdominal trauma, we did a fast exam. Unfortunately, they're obese, and it was non-diagnostic. We couldn't get a good picture. Mm-hmm. That's something we really, really need to be careful. And it's dangerous for the patient, because if you misinterpret that and tell a surgeon, no, that fast was negative, like we said, okay, maybe they're put in the back of the ER mm-hmm. and wait an hour when they have an internal bleed. So just being, and I struggle with this because I think particularly when we're training doctors, I'm like, why are we so uncomfortable saying we don't know? Mm-hmm. Well, we're not used to that, right? I'm a doctor, of course I know. And it seems like an insult to myself. I didn't know what I was doing with that fast exam. But frankly, an expert, I don't know, Victoria, sometimes if you're looking at a patient and they're just so obese that you just can't get good pictures, in a setting, not in a rushing ambulance or something. I think that's really important. But other comments?
No, I absolutely agree. You need to know your limits, and you need to know when to say that you actually can't conclude with anything. Brian, if you think about that patient you said you had a scan from another hospital and they wouldn't trust it or whatever, they want to do another scan.
Yeah.
If you had an ultrasound scanner in your pocket, and that's how small they are, you can actually put it in your pocket, and you knew what you were doing, you were trained to scan aortas, you would easily see an aneurysm, easily. And you could save that on the scanner on your mobile phone, and you could show it to the doctor taking over the patient in the emergency room.
It makes
He couldn't say, no, I don't trust this, I'm going to do a CT scan, because you know yourself, that's when the patients crash these ones with the big aneurysms.
Well, so. I'm like feeling emotional because I'm realizing that this is technology, right? This could have, been in my pocket 20 years ago and maybe done that. So how Victoria, how long does it take to set up, to stick that on the chest, just squirt gel, stick it on, turn it on? I mean, how many minutes or seconds are we talking about?
Well, if you knew what you were doing and you were trained to do it, I would say in a patient, if you didn't have like a super, super obese patient, like an average patient, it would take you maybe between 5 and 10 seconds.
Oh, so that's just awesome.
Yeah. And for me to train you to do this, I don't know, half an hour, an hour.
Oh, maybe I don't believe that. I think it'd take me
a bit before you get comfortable trusting what you see. But we're not talking 2 years in order to learn these point-of-care protocols that a scan for an abdominal aortic aneurysm would be.
Just want to add, Bram, to that. Remember now, you have a video clip or even a picture in your pocket that will help you in your arguments towards a surgeon or a cardiologist and so on. And I feel that I've done this a long time now, and I feel they actually like that we document things. They will look at the picture, and even though if they disagree with you, well, then you can have that discussion over your video or picture, and but it makes your arguments much stronger, and that helps a lot. I think you're just adding more information to them, and they like that.
This has just been totally awesome. I feel like that EMS is just growing by leaps and bounds, especially with technology like this. And so to all three of you, thank you so much for pushing the envelope forward. And maybe in 20 years from now, we'll be talking about different kinds of interventions in the field. But right now, from someone who's seen the world without this and can understand the world with this, I thank you. So does anyone have anything else to finish?
Yeah, I mean, I would just say, I'd encourage people to start with doing an ultrasound guided IV. I think that's a great place to start and very practical for EMTs. And they're just going to be different levels. And some people say, I'm going to stop there, maybe bladders and IVs. And then there's going to be the other person who's very interested in doing fast exams and cardiac and things like that. And then I always say it's like skiing. You're not going to learn by sitting and listening to someone like me. You got to get that probe in your hand, and you have to scan a lot of people. And Victoria, you can teach them to look at a normal aorta in a half an hour, but they need to see a lot of abnormals and normals, and then really get to know, again, the difference. And again, if they're 500 pounds, that I always say that's the patient that I need help with. But I'd have to say with ultrasound, that's the one where it's very, very difficult. It's still helpful in many of those, but oftentimes you have to throw your hands up, and you do have to get that formal CT or whatever. It's just the way it is.
And Gordon, I can just add, and this is a whole other topic that I'm not going to go into, but the problem is often getting the training and having qualified teachers there to train you and to mentor you and to discuss your scans with you. That's often something that puts a halt to learning something like this. But as you, Gordon, with one of your articles, you can also see how now you have available to you simulators and also remote teaching that makes this much easier. If you want to learn, there's you definitely find a way to learn.
I always say you just need one patient, meaning this first patient where you're able to diagnose something that you know from before that you were never able to do, just such a good feeling, and then just encouraged to learn even more. So it's a learning curve, but it's not too steep. You could learn this, but as with everything in EMS, you need to practice and use it in your everyday clinical life.
And what seems so great is that this can be used for so many different diagnoses. And so from all the way from Portland, Oregon to Norway, now to Houston, thank you all for being with me. This has been a great talk. And I don't know about everyone else that's listened, but I'm really excited about ultrasound and what it means for the future of EMS. I want to also invite you to check out my latest book I co-authored with 4 Arrows, who has 2 doctorates and is an expert on indigenous scholarship and hypnosis. So I just want to invite you to check it out because we introduce a method for communicating with patients on the scene of an emergency that takes advantage of some of the properties found in hypnosis. This book works to change the way we approach and interact with any kind of emergency patient in acute distress because it's going to help you be a better practitioner and use communication as a healing tool. Right now, there's just not a lot of training in how to talk to your patient. And if you've been stuck with a patient for any period of time and you need to have a conversation, it's awesome to be able to have a healing conversation. This book is called Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. You can follow the link below to find it, or you can find it literally almost anywhere you type in the name or my name. I had a friend that mailed me a book and wanted an autograph. Don't mail me a bunch of books. Just let me know that you want an autograph for the book, and I'll be happy to send you over a sticker. I have some stickers made that are pretty awesome that I'll send you that you could put in the cover.
Hi, I'm Will Chaplot from the International Pre-Hospital Medicine Institute. You might know about us because of the literature reviews that we post every month free for your review on our website at iphmi.com and also published through GEMS Online magazine every month. We've been doing them for 5 years, so now we've accumulated over 240 literature reviews over the past 5 years. And we've gotten feedback from our audience that said they'd like to have these things as desk references, so they'd had a rapid reference. Well, we've done it. And there are now 5 volumes of these books, one for each year that we've been publishing them. This is the latest version, volume 5. And as I said, in each of these, there's at least 48 literature reviews. They're all cataloged in the beginning of the book, so you can see what the topic area is, what pages those reviews are on, and how you can find them quickly. And again, these are a great reference, whether you're putting a lecture together, working on a paper, studying, whatever it is. This gives you the depth of field of the science that dictates what we do in the field or what we should be doing in the field or why we've changed the way we do things in the field. In any event, as with all of our publications, we've priced these because we want you to be able to have this book. It's only $4.99 in the hard copy here, and all 5 of them are available at that price. But you can also get them as ebooks, and they're available as ebooks from Amazon, from Apple, from Barnes & Noble, wherever you get your ebooks for the price of $2.99. So again, we don't do this with an aim towards getting wealthy. We do these because we want you guys to be able to have these materials. Relevant information, affordable information, and an access so you can get to it. So you want the hard copies, go on Amazon, $4.99. Go to your ebook store and you get it for $2.99. If you're in the business, this is the kind of material you want to have around to settle those firehouse arguments or to help you put your materials together. Thanks again. See you all soon. Thanks.
The other thing before we close that I want to share is that I'm doing a research project related to first responders who live in the United States. And I could really use your help if you don't mind being interviewed over a video call. So go to my website, fill out the form that's at professorbram.com, professorbram.com. And thank you again for listening. I look forward to sharing more insights with you in this next episode. If you enjoy EMS research, please tell your friends, like, share, and subscribe to help others get the message. And then stay tuned for the credits at the end so you can see the research articles that we talked about in today's episode.